Good afternoon. Today we shall be dealing with the ECG case number 10 in our ECG series. The title is TV inversions. What's all the fuss about? So it's a very important topic from a general practitioner point of view, from a specialty point of view, or even from a super specialty point of view, because T inversions are very commonly seen on ECGs, and you need to be able to know what to do with them and what's its significance. So let's start. Which of the following is true? T inversions are always pathological. T inversions indicate CAD, that is coronary artery disease. T wave inversions have localizing value. By this I mean that if you have T inversions in 2-3 AVF, you can say this is an inferior ischemia, or T inversions in the anterior leads, you say it's an anterior ischemia. T wave inversion in anterior leads is indicative of anterior wall ischemia. Give antiplatelets and statins unless proven otherwise. A brisk development of T wave inversion post MI is indicative of reperfusion. T wave inversion mandates antiplatelets and statins. Lastly, T wave inversion mandates cardiology consultation. So you can have a look at these options. If you require more time, you can press the pause button, and if not, you can go ahead with the video. So a very common misconception, T wave inversion equals CAD. So I've seen untold number of referrals to a cardiology center saying that this patient has T wave inversion and he started on antiplatelets and statins. So a very common misconception is T wave inversions equals CAD. So I shall try to prove this wrong during the course of this video. So let's have a look at it. So causes of T wave inversions. This is a 71-year-old male who presents with exertional dyspnea with episodic worsening for the past 13 years. You can have a look at this ECG. You can pause the video if required. This ECG shows T inversions in V1, V2, V3, V4, V5, and V6, and maybe some T inversion in say 3, maybe a very shallow T inversion in AVF. So basically T inversions in the anterior leads. Now, can you call this as anterior wall ischemia? Do you need to start this patient on antiplatelets and statins? So if you do so, you're not seeing the patient as a whole. So one, this patient has exertional dyspnea with episodic worsening for 13 years. It's extremely unlikely for a cardiac cause other than mitral stenosis or diastolic dysfunction to have a dyspnea on exertion for the past more than 5 years. So a very long-standing exertional dyspnea is not suggestive of a cardiac cause. So 71-year-old with exertional dyspnea with episodic worsening, have a look at his ECG. You can see a right axis deviation as indicated by a prominent negative wave in 1. You can see a monomorphic R wave in V1 along with T inversions in V1 to V6. This is actually a case of right axis deviation due to a right ventricular hypertrophy. In this case, the right ventricle is probably the dominant ventricle in this patient, as electrocardiographically at least. So this is actually RVH with RV strain. In the background of a long-standing dyspnea for 13 years, you start thinking of a respiratory disease causing RVH, that is cor pulmonary. So this is actually, you can see this patient has a COPD as indicated by you can see emphysematous chest fields on both sides. It's actually a case of COPD and cor pulmonary. This does not mandate antiplatelets. So in the case of 12-year-old with fever, you can see a certain degree of sinus tachycardia with T inversions in V1 to V3. Again, not a CAD. So 64-year-old with loss of consciousness, you can see giant T inversions in V2 to V6 and T inversions in 2-3 AVF. What are giant T inversions? If you have T inversions of more than 10 millimeters in the chest leads or more than 5 millimeters in the limb leads. So these are actually giant T inversions. Another thing you can see is a prolonged QT interval. Pick up midpoint between the RR interval. If the T wave crosses it, you have a prolonged QT interval. So you have giant T inversions with prolonged QT interval. In the background of a loss of consciousness, you strongly suggest a CNS pathology. This was actually a case of subarachnoid hemorrhage. Now imagine if you are given antiplatelets, heparin or statin for such a patient, it could prove potentially fatal. So again, T inversions, not a CAD cause, but another life-threatening cause. 50-year-old with CA colon, sudden onset dyspnea followed by syncope. You can see T inversions in the anterior leads, V1 to V4, T inversions in 2, 3, and AVF. But also you can see you have an S wave in 1 a Q3, a Q wave in lead 3, and a T inversion in lead 3. There is S1, Q3, T3 of pulmonary embolism, and the T wave inversions in the inferior leads and the anterior leads are actually due to the pulmonary embolism. So whenever you have new onset T inversions in the inferior leads and the anterior leads, in the background of sudden onset dyspnea, think of pulmonary embolism. So this was described by Marriott. So this is actually again a life-threatening cause, but not CAD of T inversion. This is again left bundle branch block, T inversions in V6, 1 and AVL. These are part of repolarization changes occurring due to a left bundle, not again CAD. Right bundle branch block, T inversions in the V1 to V3. Again, these are part of repolarization changes occurring in a right bundle branch block, not related to CAD. You can see hypertrophic cardiomyopathy causing T inversions in the inferior leads and in the anterior leads. You can see very prominent QRS complexes. Again, T inversions are due to a muscle disease rather than a coronary artery disease. So intrinsic muscle disease of hypertrophic cardiomyopathy causing the T inversions. Again, nothing to do with CAD. Patient on digoxin, you can see the sagging ST depression with the T inversions in the anterior leads. This is again has nothing to do with the CAD, it's just purely due to Digi effect. So let's go. 64-year-old female with new onset retrosternal burning chest discomfort at 2 a.m. lasting for 30 minutes, relieved by PPI. So this ECG, have a look at this ECG. This was already described previously. This is actually a Wellens syndrome. I shall post a link of this video in the description, so you can have a look at that. So this is actually a cardiac pain which requires admission. 2 hours later, when the patient has no chest pain, you can see that the T waves are inverted in the anterior leads. So this is actually a case of pseudo-normalization of the T wave. So during the time of the chest pain, the T waves become normal or upright, and subsequently it becomes inverted. This is called pseudo-normalization. This is very suggestive of a coronary artery disease, especially in the background of a typical angina. So these T inversions are due to coronary artery disease, and this is actually a life-threatening condition, because if you don't treat this, within the next few weeks, he goes in for an extensive anterior wall MI. Again, this is a case of post-MI patient. You can see that this patient has suffered an anterior wall MI. You can see QS complexes in V1 to V5 with T inversions in V1 to V6. So this is actually a post-MI, again a CAD cause of T inversions. So when do you consider a CAD? You can see several cases where you can have normal variants, you can have non-cardiac conditions leading to CAD, you can have cardiac conditions leading to CAD, which are not cardiac conditions leading to T inversions, which are not part of CAD, and finally you can have coronary artery disease. So when do you consider coronary artery disease? One is when you have dynamic ST T wave changes, as like pseudonormalization as in the previous case. 2, when patients have symptoms suggestive of CAD. So if the patient has exertional chest pain, or if he has rest angina, or if he has a new onset of exertional dyspnea, fatigue, on those cases you can start considering whether these T inversions are related to the CAD. And finally, when you have risk factors, like if you have T inversions in a 22-year-old female who's completely asymptomatic, it's different from a 54-year-old male who's diabetic, dyslipidemic with a strong family history. So you consider risk factors also when you assess T inversions. So dynamic ST T wave changes, patients having symptoms of CAD, and risk factors. Just to highlight, there are T inversions can occur due to normal variants. So hyperventilation, you ask a patient to hyperventilate, you can see the T inverts slowly in V1 to V3, can have shallow T inversions. Heightened adrenergic states like pain, panic attacks can also cause T inversions. Postprandially, after food, some people can have T inversions. Children can have T inversions, especially less than 12 years of age. Persistent juvenile pattern is a pattern which occurs in Afro-Caribbean women with T inversions in the anterior leads from V1 to V4, which is less than 3 millimeters. So these are all normal variants. Finally, ECG lead misplacement and lead reversal can lead to T inversions. You can have plenty of normal causes of T inversions also. So finally, T inversion is normal in lead 3, AVR, and V1. I've seen so many cases which have been sent for a cardiology referral saying that they have T inversions in AVR and V1. So remember AVR, V1, and lead 3. Look at the right side of the heart in some capacity. So these can show T inversions. So T inversions are normal in lead 3, AVR, and V1. T inversion is not equal to CAD. T inversions can be seen in normal individuals. They can, like in hyperventilation and postprandial state. They can be seen in non-cardiac conditions like you can have in pleural effusions, you can have in pneumothorax, or even in subarachnoid hemorrhages. You can see in non-CAD cardiac conditions, which is like you can have in case of myocarditis, cardiomyopathies, pulmonary embolism, and finally coronary artery disease. Use your clinical judgment. Do not treat the ECG, treat the patient as a whole. So if you find features of pulmonary embolism, you diagnose it due to pulmonary embolism. If you examine and find a pneumothorax, you assume that the T wave inversions are probably due to the pneumothorax and not due to the coronary artery disease. So use your clinical judgment and to diagnose the cause of T inversions. And if you find there are no causes, there is a tentative called non-specific ST-T wave changes where you are not sure what the cause is. So last we go for localization. So have a look at this ECG. Is this you can see T inversions in V4 to V6 and the one AVL and the inferior leads. Now is this inferior wall ischemia, inferior wall plus lateral wall ischemia, or you cannot comment. If required, you can pause the video or you can go ahead. So this is a frequently seen referral to a cardiology center where the diagnosis is an infralateral ischemia. The correct answer is you cannot comment. So which of the following localizes on ECG? ST elevation, ST depression, T inversions, or Q waves? Now T inversions and ST depressions constitute representation of ischemia on an ECG. ST elevation is represented by injury, and pathological Q waves represent infarct. So if there is a coronary artery disease, T inversions and ST depressions are representations of ischemia, ST elevations are representations of injury to the myocardium, and finally pathological Q wave reflects an infarct. Remember, ischemia does not localize on ECG. This must be highlighted and put in inverted commas because this is frequently got wrong by several doctors. Ischemia does not localize on ECG. You cannot say that a patient has T inversion in V1, V2, V3, and V4 and say this patient has anterior wall ischemia. If he has T inversions in 2, 3A, you cannot say this patient has inferior wall ischemia. So again, ischemia does not localize on ECG. This must be always kept in mind. Injury and infarct do localize. That is, if you have an ST elevation in V1 to V4, you can say it's an anterior wall MI. Similarly, if you have an ST elevation 2, 3F, you can say it's an inferior wall MI. Infarct localizes. If you have a Q wave in pathological Q wave in the anterior leads, you can say it's an old anterior wall MI. If you have a pathological Q wave in the lateral leads, you can say it's an old lateral wall MI. So ischemia does not localize. It's a good idea to eliminate terms like inferior ischemia or anterior ischemia from your vocabulary. I've seen several patients being referred as this is a case of inferior ischemia or anterior ischemia. Kindly evaluate. So again, it is difficult to diagnose or localize the CAD on the ECG purely with T inversions or ST depressions. Again, this is a typical case. This was actually a 35-year-old female who was on antipsychotic drugs, who was having long-standing hypertension for the past 10 years, who refused to take antihypertensive medications. You can see this is actually, I can see marked ST depression with T inversions in the V4 to V6 and T and 1 and AVF, T inversions in 2, 3 AVF with ST depression. These are pure with marked QRS voltages. Look at the QRS voltage. It's not contained within the ECG strip. This is actually purely a case of hypertensive heart disease. That is, you have LVH due to hypertension. So again, do not go and diagnose this as infralateral wall ischemia and start the patient on antiplatelets and statins. This patient requires hypertension control rather than antiplatelets or statins. 65-year-old with typical angina, you can see the first ECG is during the time when the patient has chest pain. This is normal, and you can see when the patient is chest pain free, it inverts in T wave inverts in V2 to V6. This is actually pseudo normalization of the T wave. This indicates Wellens phenomenon. This indicates a proximal LAD tight lesion, which requires invasive treatment. So again, if you this is a T inversion. Again, this is a common misconception that this T inversion localizes. Actually, it is not the T inversion which localizes. This is the T becoming upright or actually an ST elevation which localizes in a Wellens phenomenon rather than the T inversion. So even in Wellens phenomenon, it is actually the T becoming upright or becoming having an ST elevation which localizes rather than the T becoming inverted. So again, post MI also you can see that there are T waves in V1 to V6, and we can say this is an old anterior wall MI, but actually it is a pathological Q wave which localizes. You can see QS complexes in V1 to V4. So in this case, you can see the Q is the way which localizes, not the T inversion. So 46-year-old asymptomatic male referred for ECG changes during pre-op evaluation. You can see some biphasic T inversions in V1 to V3 with a T inversion in V4. What do? You start on aspirin and statin, do a TMT, do a trop-T, do an echo, do an angiogram. So again, this patient is asymptomatic. I've seen untold number of patients like this being prescribed aspirin and clopidogrel or statin, some form of combination of these drugs, and they are labeled as CAD. They take these drugs for 10 years, 15 years. Now, when they come to another doctor, no doctor or invariably nobody shows the guts to stop these drugs, because no one can say when such a patient develops an MI and they don't want to take the blame of stopping the drugs and the patient subsequently developing an MI. So this is an asymptomatic patient. There is no role for aspirin or statin. There's no role for a TMT, trop-T. Actually, there is no role for an echo in pre-op evaluation unless you find some clinical findings. And the CAG is absolutely not indicated. People have done a CAG in such patients, and you find a incidental lesion and you go and stent that lesion. This patient ultimately ends up with a stent you don't require. So is this anti-revolve ischemia? It is not possible to say because T-wave inversions do not localize. So again, you can see this is a patient who is representative of many patients who actually come to your OP who are on statins and antiplatelets. Nobody is clear what the reason is why they have been started. It's mentioned as old CAD. We're not quite sure what the reason is, and he continues taking aspirin and statins for life. So a very common misconception: T-wave inversion equals CAD. T-wave inversion may be equal to CAD. We are not very sure in a given case. It can be a normal variant. It can be a non-cardiac condition. It can be a non-CAD cardiac condition. And finally, CAD. Use your clinical judgment. Just to show some referrals which come to your OP, ECG shows changes. Often the most frequent referral which is seen. The patient is afraid and he says that the ECG shows changes. ECG shows variation, query CAD. ECG shows a block in the heart. Patients are started on aspirin, clopidogrel, or statin, some combination of these drugs, and referred. So be judicious in starting antiplatelets for patients, because nobody is going to stop these drugs, and these patients are labeled as CAD and they have this burden throughout their life. If they are a manual laborer, they generally stop their activities. It proves a burden for their livelihood. So I'm not saying don't start. I'm saying be judicious in starting, use your judgment. And if you are unable to do so, you send it to a higher specialist. ECG shows lateral wall ischemia. Again, this is absolutely wrong. T-wave inversion or ST depression does not localize. Finally, take-home messages. T-wave inversion not equal to CAD. They can be seen in normal individuals, non-cardiac conditions, non-CAD cardiac conditions, and lastly, coronary artery disease. Use your clinical judgment. Do not treat the ECG, treat the patient. Finally, be judicious in starting antiplatelets and statins. You should start in the right case and not in every case. Ischemia does not localize on ECG. T-wave inversions and ST depressions do not localize. Injury and infarct localizes. That is, ST elevation and a pathological Q wave does. It is a good idea to eliminate terms like inferior ischemia and anterior ischemia from your vocabulary. Try to avoid these terms. So which of the following is true? T-wave inversion is always pathological. It is false. You can have normal variants. T-wave inversion indicates CAD. That is true. It can indicate if you have an appropriate clinical background, but it is not equal to CAD. T-wave inversion has localizing value. It is wrong. It's false. T-wave inversion anti-release indicates anterior wall ischemia. Give antiplatelets and statins unless proven otherwise. It is false. It can be seen even in normal variants and non-cardiac conditions. A brisk development of T-wave inversion post-MI is indicative of reperfusion. That is true. If you have a brisk development of T-waves within 4 hours, you can probably suggest it is a reperfused myocardium. T-wave inversion mandates antiplatelets and statins. Again, that is false. All T-wave inversions do not do so. T-wave inversion mandates a cardiology consultation. Again, that depends. I leave it to the given doctor, because if you're not confident, you send for a cardiology consultation. If you're able to distinguish the cause, you need not do it. So finally, please like, share, and subscribe. And if you like the video, press the bell icon to get notified when a new video uploads. Thank you.